tumors. Yes? Yes, okay. Epithelial tumors. Time and in the conference. Okay, epithelial tumors. It's frequently possible to recognize precursor lesion of malignant tumors. Often these are benign tumors such as colorectal adenomas, which precede colorectal adenocarcinomas. In other situations, a benign tumors is not present but morphological abnormalities may still be identified. Dysplasia is intraepithelial neoplasia, a malignant disturbance of cell proliferation and maturation. It's generally assumed that once initiated dysplasia will progress to an invasive malignant tumor. Dysplasia is recognized by pleomorphism of cell, hypochromatic nuclei, and increased mitotic activity, loss of polarity, orientation of cells, disordered maturation, and absence of invasion. Skin papilloma is benign epithelial tumors. Benign epithelial tumors. Skin papilloma. Localization: skin, size 1 to 2 centimeters, shape round, surface papillary, type of growth extensive and exophytic. Slide skin squamous papilloma. Number 1, papillary structure of tumors. Number 1, papillary structure. This is papillary structure. Number 2, increase number of epithelial cell. Number 3, preserve polarity. Please 1 minute. Okay, number 1, papillary structure of tumor. You can see this slide, yes? Write me, please. Yes, okay. Number 2, increased number of epithelial cells. Number 2, this is increased number epithelial cells. Please 1 minute. Okay, sorry. Number 3, preserved polarity of epithelial cells. Number 3, 3, preferred polarity of epithelial cells. Number 4, preserved basal membrane. Number 4, this is basal membrane. Number 4, basal membrane. Number 5, stroma of tumor. Number 5, stroma of tumor. Number 5, this is stroma. This is connective tissue with blood vessel. And number 6, vessels of tumor. Number 6. In this slide, this is papillary structure, and numerous epithelial cells and blood vessels, and stroma of tissue tumor. Next. Squamous cell carcinoma of the esophagus. Squamous cell carcinoma of the esophagus. Squamous cell carcinoma is a collective term for carcinoma that mimic squamous epithelium, exhibiting filamentous eosinophilic cytoplasm, demarcated cell borders, and are often keratinization. Carcinoma may be grading, well differentiated, low grade, intermediate differentiated grade, and poorly differentiated high grade malignancy. And in this tissue, in this tumor, malignant tumor, carcinoma is malignant tumor from epithelium, squamous cell. Number 1, tumor cell with sign of cell atypia. This is cells, tumor cells with atypia. Number 2, area of invasive growth of cancer. This is invasive growth. Because shape in this tumor may be irregular because of growth. And number 3, stroma of tumor. This is vessels in the tumor, stroma of tumor. These tumors, this is squamous cell carcinoma. We can see numerous cell of tumor, and this is stroma. And this invasive growth in the tissue. Fibroadenoma of the female breast. Number one, connective tissue of tumor duct by gland. Number 1, connective tissue duct by gland, between gland. And number 2, epithelial component of tumor. This is epithelial component of tumor. We can read and study stage of invasion development. First stage, dysplasia in the type 1. Second stage, dysplasia type 2. Third stage, dysplasia type 3. And fourth stage, this invasion. Next. Endometrial adenocarcinoma. endometrial adenocarcinoma. This adenocarcinoma is collective term for carcinoma of the mucosa or exocrine or endocrine glandular epithelium with formation of lumen within the tumor cell complex or lumen within the tumor cells themselves in the form of inner surfaces. This endometrial adenocarcinoma, number one, cancer gland. Number one, cancer gland. This is gland, 3 gland, cancer gland. Number two, differential size. We can see small in the size and big in the size. Small in the size and big tumor glands, cancer gland. Number three, losing of polarity. Losing of polarity. Number three, losing of polarity. In the norm, all cells in the basal membrane. In the tumor, in the malignant tumor, cells are each other. Number four, mitosis. Number four, mitosis. This is cells with mitosis, and these cells with mitosis. Number five, destruction of basal membrane. Number five, destruction basal membrane. This is destruction basal membrane. And number six, stroma of tumor. Stroma of tumor. This is stroma of tumor. Next, gross papillary mucinous cystadenoma of the ovary. Localization in the ovary. This is uterus, tube. This is uterus and tube, uterus and ovary. Localization in ovary. Size 5 centimeters, maybe larger. Shape round and oval, only round and oval. Surface smooth. Type of growth inside the wall and expansive. This is benign tumor. This is suffix oma, and benign tumor. Inside the wall and expansive. Borderline prominent. Slide. Adenomas is tumor arising from glandular parenchymal or mucosal epithelium and consisting of proliferative epithelial folds or tubules in or on a stroma. Stasis of secretion leads to development of chambers, numerous chambers. This is numerous chambers. Okay, in the slide, number one, epithelial surface of tumor. Epithelial surface of tumor and capsule. This is capsule. This is surface. Number two, papillary structure. Number two, papillary structure. This is papillary structure. Between this papillary structure, chambers. Number two, papillary structure. This is papillary structure. And number three, cyst cavity of tumor, chambers or cavity of tumor. Number three, cavity of tumor. Choriocarcinoma. Number one, choriocarcinoma is maybe only in the uterus. Choriocarcinoma. Number one, cytotrophoblast. Number one, small cells, cytotrophoblast. This is cytotrophoblast number one. Number two, syncytiotrophoblast. Number two, syncytiotrophoblast. This is big multinucleated cells, syncytiotrophoblast. Syncytiotrophoblast number two. And number three, blood vessels, stroma. Number three, blood vessels, stroma. This is stroma. Electron micrograph growth hormone secreting pituitary adenoma. The tumor is composed of atypical cells layers that are tightly pressed to each other and contain numerous cytoplasmic neuroendocrine granules. This is neuroendocrine granules. This is granules. Numerous granules. The supportive stroma is absent. Stroma is absent. We can't see stroma. Gross renal cell carcinoma. This is foci focus of renal cell carcinoma. Localization kidney polus. Localization kidney polus. Size 2 to 5 centimeters. Shape irregular or round. Type of growth invasive and borderline not prominent. Case. Case 34. Read and questions. What is the most likely clinical diagnosis? This is squamous cell carcinoma. Why? White thickening on the lateral border of the anterior in his tongue and biopsy to confirm lesion. Number 2, is the biopsy confirm the clinical diagnosis? What further examinations you would recommend? I would recommend cytology and lymph node examination because I will study metastasis way. Number 3, what is the common site of spread of the lesion? Regional lymph node. Regional lymph node. This is metastasis in regional lymph node. Number 4, what other variants of tumors can develop in the tongue? Adenoma, adenocarcinoma, leiomyoma, leiomyosarcoma, fibroma, and fibrosarcoma. And number 5, describe histology of the precancer lesion of the tongue. Leukopenia and white patches. Next case. Read and question. What is the differential diagnosis? I will differential adenoma benign and adenocarcinoma malignant. What is the characteristic histological appearance of the benign parotid pleomorphic adenoma? Celotypia and expansive type of growth. We can see pleomorphic gland adenoma, and we can see well circumscribed outline form. Maybe this is malignant. Maybe. Celotypia and expansive type of growth. Number 3, what precautions must be taken during surgery and why? Isolate the site from blood and flow and lymph flow and investigate of tumor. Number 4, describe other histological types of adenomas. Fibroadenoma, maybe, papillary adenoma, cystadenoma, cystadenoma, and tubular adenoma. And number 5, what is the common site for spread of the parotid carcinoma? Maybe regional lymph nodes too. And last case. Question, what is the association between endometrial carcinoma and endometrial atypical hyperplasia? Hyperplasia is precancer process. Number 2, how do endometrial carcinomas spread? We can open page number 99, and we can see endometrial adenocarcinoma, cancer gland, differential size, losing of polarity, mitosis, destruction of basal membrane, and stroma of tumor. Number 3, how are endometrial carcinomas staged? what is the prognosis for such patient? This stage I explain you four stage: dysplasia type 1, 2, 3, and invasion. This is, in this case, severe cytological and architectural atypia, and maybe invasive, fourth stage, invasive. Number 4, describe other histological types of the endometrial adenocarcinoma. I explained you page number 99. And what further investigation may be helpful and what would confirm the diagnosis? This is hormone examination. Hormone examination, common, and hormone examination is very important. Very important. Okay, now I end explaining for today. And now, in the 3 o'clock, in the now, I will explain second time. I will explain second time. Questions. What is the differential diagnosis? Maybe adenoma, benign, or malignant adenocarcinoma. Why? Parotid pleomorphic glands adenoma. In the biopsy, it's benign adenoma. Maybe we can see adenocarcinoma. Number 2, what's characteristic histological appearance of the benign parotid pleomorphic adenoma? Characteristic histological, maybe cell atypia and expansive type of growth. This is benign. Expansive type of growth, benign. Adenoma. Cell atypia is a sign of malignant tumor. Number 3, what precautions must be taken during surgery and why? We must isolate the site from blood flow and lymph flow and investigate of tumor. Number 4, describe other histological types of adenoma. Fibroadenoma may be papillary adenoma, cystadenoma, tubular adenoma. Number 5, what is the common site for spread of the parotid carcinoma? Regional lymph nodes, maybe. Metastasis in regional lymph nodes. And case 36. Read, please, this case. And question, what is the associations between endometrial carcinoma and endometrial atypical hyperplasia? Hyperplasia is precancer process, and precancer process, and hyperplasia may be pre-carcinoma in the endometrium. Number 2, how do endometrial carcinoma spread? Endometrial carcinoma maybe in the lymph flow and blood flow. This is metastasis. Number 3, how are endometrial carcinoma staged? And what is the prognosis for such patients? Stage of invasion development, first stage is dysplasia type 1. Second stage, dysplasia type 2. Third stage, dysplasia type 3. And fourth stage is invasion. Dysplasia may be good prognosis, maybe. But invasion is poor prognosis. Number 4, describe other histological types of the endometrium adenocarcinoma. Histological types and histological characteristics in the page 99. We can see, I open you for you, this endometrial adenocarcinoma, cancer glands, differential size in the glands, maybe small and maybe big, losing of polarity, mitosis, destruction of basal membrane, and stroma of tumor. And 5. Question. What further investigation may be helpful and what would confirm the diagnosis? Hormone examination. We can investigation level of hormone, and we can make the prognosis of this process. Okay, I end explaining unit 14 and 15, and I wait from every student your workbook all day in this week, and results of your tests in the site of Sechenov University. Goodbye.